Hello, my name is Jody. I'll be your nurse practitioner student today. First off, we're just going to be doing a basic head-to-toe assessment, so just let me know if you have any questions or any discomfort. So to begin with, I'd perform hand hygiene. Let's see here, and then can I have your name?
Jamie.
Your age?
33.
And your ethnic background?
Caucasian.
Perfect. And then so to begin with, I'm going to ask you some simple questions here, just to gauge your orientation. So can you tell me where you are right now?
The doctor's office.
Perfect, thank you. What day of the week is it?
Saturday.
Awesome. And what month is it?
June.
Perfect. Jamie is a healthy 33-year-old. He appears well-developed. He's a male, alert, oriented ×3, pleasant and responsive. He's dressed accordingly. Appears to be in no apparent distress. His posture is upright, and his overall skin color is uniform and congruent with his ethnicity. Alright, so to begin with, we're going to assess your cranial nerves, and we're going to begin with cranial nerve number 1, which is the olfactory, and this mediates the sense of smell. Let's see here. So first we're going to check with patency. So if you could please occlude one nostril, and then just breathe through the other one. Perfect. And then do the same thing with the opposite nostril there. Thank you. So both nostrils are patent, and good airflow is flowing through both. And then can I have you close both of your eyes again here? Or just close both your eyes here.
Mm-hmm.
And then occlude your left nostril here.
Yep.
And then just tell me what smell you are smelling. What are you smelling?
Peanut butter.
Perfect. And then can you occlude your other nostril?
Yep.
What do you smell in that one?
Lemon.
Perfect. Patient was correctly able to differentiate the two smells that we had here today. And then, so next we'll be looking at cranial nerve number 2, which is the optic nerve. And to check this, we're gonna be using a Snellen chart, which we have placed just on that wall over there. Do you wear glasses?
No.
Perfect. Let's see here. So to begin with, we're gonna have you I'll cover your right eye here, and just look at that chart and tell me what letters you see here.
DAPON.
Perfect. So patient has good vision, 20/20 in the left eye there. And then we'll do the same thing with your right eye here. Just read the smallest line that you possibly can.
LNAKE.
Perfect. So that eye has good vision as well, and it is 20/20 in the right eye, just like the left eye was. And then, so next we'll be checking your visual fields using the confrontation test. Let's see here. So we're gonna cover your left eye here first. If you want to hold this and just cover your left eye for me.
Yep.
And then let's see here. So you're gonna look at my nose and nowhere else. And then tell me how many fingers you see.
3.
Perfect. And then if you cover the right eye here, we'll do the same thing here.
Okay.
And then look at my nose and nowhere else. And then tell me how many fingers I have up here.
4.
Perfect. So I'll take this from you here. Thank you. Visual field is intact. No defects. No defects found using the confrontation test. And then next we'll be using the scope here. So grab this tab here. So next we'll be doing a fundoscopic test using the ophthalmoscope. So I'm going to have you look straight ahead and look at, just focus on one letter on the chart over there.
Mm-hmm.
And I'm going to start by looking in your right eye here.
Okay.
And I'm getting pretty close here. Distance. And then red reflex is visible and intact. And then I'm going to go in close here. Optic disc is clear, round, creamy pink color. Margins are sharp. Central area of the physiologic cup is pale. And then the cup disc ratio is less than half. No swelling noted, or increased cupping noted. That's not noted. Let's see here. And then the retinal background is red orange in color, and the macula is slightly darkish. Vessels, the arteries appear bright red, veins are slightly purple, and then no exudates or hemorrhages visible. Perfect. And then we'll actually do the same thing on your opposite eye here. I'm gonna kind of crawl up here. So do the same thing. Just keep focusing on that letter there.
Yeah.
Perfect. Thank you. And then next we'll be looking at cranial nerves 3, 4, and 6. These are all motor nerves, and they mediate the muscles that help move the eyes and the extraocular movements of the eyes as well. So here, cranial nerve number 3 is the oculomotor. It mediates pupillary constriction, raises eyelids via the levator muscles and the other muscles of the eye, the superior medial and inferior rectus, and the inferior oblique muscles. Cranial nerve number 4 is the trochlear. It's the inferior medial eye movements, and that's mediated by the superior oblique muscles. Cranial nerve number 6 is the abducens, and that's lateral eye movements, and that's mediated by the lateral rectus muscles. And then here, let's see, where's my pen light? Oh, there's it. Here, I'll just be shining a light in your eyes here. So first I'm going to check your pupils for cranial nerve number 3. So I'm going to have you look straight ahead at the same the Snellen chart over there. Let's see here. Perfect. Perfect. So direct response is intact. And consensual response in opposite eye is intact. Pupils were roughly about 4 millimeters in diameter, and both pupils were equal on each side, round, and they both reacted to light. Let's see here. And then next I'm going to test for accommodation. So look straight at that sign again there. And then look at my finger here. Perfect. Let's do that one more time, actually. Look straight at the sign there, and then look at my finger here. Perfect. So accommodation is intact. Patient has perla. Pupils equal, round, reactive to light, and accommodation is intact. So next I'm going to test for extraocular eye movements, and then we'll be using the 6 cardinal fields to test eye movement here. So just follow my finger here. Perfect, thank you. So the eye movements were smooth, full. I didn't see any nystagmus or any paralysis of the eye muscles. And then next I'm going to perform the corneal light reflex. So I'm going to have you look straight at the chart here. And then I'm just going to shine a light at the bridge of your nose here. Let's see, so just keep looking at the chart there. Perfect. And then I saw a symmetric light reflex with the corneal light reflex test. And then now I'll be performing the cover-uncover test to check for any misalignment, ocular deviation, or strabismus. So what we're going to do with this one here is we're going to have you look straight at the chart there and just focus on one letter. One letter here for me. So grab this here again. Let's do that one more time. Perfect. So both eyes remained aligned. No ocular deviation was noted. And then next we're moving on to cranial nerve number 5, which is the trigeminal nerve, which is a mixture of both motor and sensory functions. And to test the motor part of the nerve, we'll test lateral jaw movement here. So I'm gonna put this here. I'm just have you move your jaw side to side here, and then I'm just gonna feel on both sides of your mouth here for the muscle of mastication. So you just grit your teeth side to side. Perfect. Thank you. And then we got a nice strong response from the masseter muscles there. And then to test the sensory part of the trigeminal nerve, I'll be testing the sensation of your eyebrows, cheeks, and chin using a cotton swab and then a sharp object here. So we'll grab those and we'll bring them over here. Let's see here. So if I could just have you close your eyes and then just tell me if you feel dull or sharp sensation here. Let's see here. So start up here. What do you feel there?
Dull.
Perfect. How about there?
Dull.
Here.
Dull. Dull. Sharp.
Perfect. Thank you. So we had good sensation was intact for the 3 distributions of the trigeminal nerve. And next we're going to be moving on to cranial nerve number 7, which is the facial nerve. And that again is a mixture of both motor and sensory function. And then to test the sensory part of this nerve, we would test taste of the anterior 2/3 of the tongue. And to test the motor part of this nerve, we test the movement of the facial muscles. So if I could have you raise your eyebrows for me. Thank you. Show your teeth. Smile. And then puff out your cheeks. Perfect. Thank you. Cranial nerve number 7 is intact with symmetric movements bilaterally. Let's see here. And then we're going to move on. We're going to test your hearing, acoustic nerve here, and that's cranial nerve number 8, and that is a sensory nerve. Let's see here first. So to begin with, we're going to do the whisper test here. Let's see here. So if I could have you occlude your left ear actually for me, kind of plug it there if you can. Perfect. And then I'm just going to whisper 3 words into your ear, and then just repeat it back to me if you can.
Happy yellow January.
Perfect. And then if you could plug this ear for me, and we'll do the same thing with your left ear here.
Happy New Year January.
Perfect. Thank you. You can relax. So hearing is intact bilaterally using the whisper test. And then next we're going to be doing the Weber test here. So I'm going to grab a couple tools here. So you just sit calmly there, and then I'm just going to tap this fork, and then it's going to go above your head here, and just tell me if you hear any stronger in either one of your ears here. Alright, so here we go.
About even.
About even? Perfect. So the no lateralization of sound here to equally in both ears. If sound had lateralized to the affected ear, that would be a conductive hearing loss. And if the sound had lateralized to the The non-affected ear, that would be a sensorineural hearing loss. But he was good there here since he heard it bilaterally in both ears. Next, we're going to be doing the Rinne test. We'll be using this for the Rinne test. Let's see here. So again, I'm going to tap this. I'm going to place it behind your ear, and then just let me know when you stop hearing the ringing. And then after that, I'll move it in the front of your ear, and then tell me when you stop hearing that as well.
No. No.
Perfect. So he heard that in roughly about a 2-to-1 ratio, which is a normal response, and that's to be expected. So there is no conductive or sensorineural hearing loss. And then next, we're going to be looking at cranial nerve number 9, which is the glossopharyngeal nerve, and cranial nerve number 10, which is the vagus nerve. They'll be assessed together, and they're another mixed one as well. They're motor and sensory nerves. So for sensory, cranial nerve number 9, that's the taste, posterior of the 1/3 tongue and throat. Cranial nerve number 10 is a motor nerve, and that mediates the muscles of the larynx and pharynx, swallowing and phonation. So what I'm going to have you do is open your mouth here. So to assess this one, I'm going to have you open your mouth and just say ah for me. So the vulva rises and falls midline symmetrically. No vulva deviation to either side. And gag reflex was intact. Let's see here. And then can you swallow for me? Perfect. So cranial nerve number 9 and 10 motor functions were intact with the swallowing test there. And then cranial nerve number 11, that's the spinal accessory nerve, and that is a motor nerve as well. So this, we're going to be using your shoulder muscles here. So I'm just going to put pressure on your shoulders, and then just raise against them if you could for me.
Yep.
Perfect. He shrugged against resistance, no issues there. And then I'm going to place my hand on each side of your cheek here, and then just turn your neck. Perfect. And then the same thing on this side. Perfect. Thank you. So that was good. He could push against with full resistance with both the neck muscles and the trapezius muscles. So cranial nerve number 11 is intact, and that leads us to the final cranial nerve number 12, which is the hypoglossal, and it's another motor nerve. And then this mediates the movement of the tongue. So what I'm going to do here is have you stick out your tongue for me. Perfect, thank you. The tongue was midline. I didn't notice any tremor or any deviations noted. And then can I have you push your tongue to one side of your cheek here? Perfect, thank you. Patient, he was able to push his tongue to each side of his cheeks there. So cranial nerve number 12 is intact. Here. And then next we're going to move to assessing kind of like the head and face area here. Let's see here. So I'm just going to look at your hair here. Perfect. His hair is soft. It's evenly distributed. There's no signs of alopecia. Let's see here. And then scalp and skull here. It's normal cephalic. No masses, lesions, drainage, or any tenderness are noted. And as far as facial features, everything's symmetric. Skin is smooth, kind of pink in color overall, dry. There's no redness or swelling noted anywhere. Let's see here. And then I'm just going to palpate some of your sinuses here. So I'll palpate above your eyebrows here, and then right around your nose there. So we'll start with the frontal sinuses, and then just let me know if you have any pain or tenderness when I do these. Anything there?
No.
Any pain or tenderness with either of those?
No.
Perfect. So we palpated both the frontal and maxillary sinuses. He has no pain or tenderness, no signs of infection or anything like that. And then next we'll be looking at your eyes here. Let's see here. And then, so the eye structures I would say are symmetric. There's no ptosis noted, no drainage, crusting, lesions, or edema around under the eye at all. Let's see here. Sclera is non-icteric. And then I'm just going to kind of pull down your eyelids here, kind of check for any redness or anything. That's good here. So the conjunctiva was pink, moist. There was no discharge in there. And then the cornea was clear and without any opacities, and the iris was flat. All right. So next we're going to look at your ears here. And it looks, ears are within alignment in the outer canthus of eyes. So the auricle was non-tender. There was no redness or tenderness, no swelling, discharge, and then as far as the mastoid process, he didn't report any tenderness with that either. There's no masses noted bilaterally there. Let's see here. And then next we'll be performing the tug test. So I'm going to actually kind of pull on your ears here. And then just let me know if there's any kind of pain or tenderness or anything like that. Any pain or tenderness there?
No.
Perfect. So there was no tenderness or pain noted, and then no signs of otitis externa there. And then next we're going to be using the otoscope here. Let me just switch out the touch. So I'm just going to be taking a look inside your ears here. We use the left hand for left ear. Get this one on here, sorry. Any pain or discomfort with that there?
No.
So the external auditory canal was pink. There was no excess cerumen in there. No lesions, ulcerations, or masses. The tympanic membrane was a pearly gray color. No bulging, no redness or any erythema noted. No effusion. And then the left cone of light was at 7 o'clock roughly, I would say. And then the right cone of light was about 5 o'clock. And then the handle and short process of the malleus was visible as well. So we're gonna do the same thing with the opposite ear there. You could slightly turn that way for me. And I'm just gonna pull on your ear again. Thank you. Any pain or tenderness in that ear?
No.
Nothing at all. Thank you. next we're going to use the same device. We're going to look at your nose. I'm just going to change out the caps here. Perfect. So you just tilt your head back a little bit there. Then we're going to check your left nostril here as well. Perfect, thank you. You still doing okay?
Yep.
Perfect, thank you. So the mucosa was pink, moist. I didn't notice any ulcerations or any lesions, bleeding, or any polyps inside his nostrils. Inferior and the middle turbinates are visible. The superior turbinate, we can't it was not visualized. And then I would say the septum was a midline. It wasn't to either left or right in the middle there, which is what we would like to see here. And then next we're going to be assessing kind of your throat, lips, kind of all that area. As far as lips, I would say there's no ulcerations, lesions, cracking, or any dryness. Let's see here. And then I'm just going to take a look at your gums here, so you just open your mouth here for me. Perfect, thank you. Perfect. So gums are pink, moist, no bleeding, ulcerations, or any swelling. Teeth are well aligned, good hygiene's noted. Let's see if you open wide for me. So that's good there. The roof of the mouth and floor of the mouth is pink, moist. No lesions or any ulcerations noted in there as well. And then have you stick out your tongue for me? Perfect. So the tongue is pink, moist, no fissures, white patches or ulcerations. And then open real wide for me and say ah.
Ah.
Perfect. So tonsils are 2+, and they fill about 50% of the space, which is to be expected and what we want. All right. And then next, I'm going to inspect the oropharynx and describe the Malampati airway classification. This class is graded from a scale of 1 to 4. 1 means the full soft palate and the vulva and pillars are completely visible. 4 means we only have the hard palate visible. And this is an estimate for amount of space and whether amount of space for intubation and whether the patient is at risk for sleep apnea or obstructive sleep apnea. So I'm going to use the pen light again. So if you could open your mouth and then just say ah for me again.
Ah.
Perfect. Thank you. So the whole of vulva and soft palate were visible. So I would give our patient here today a grade of a 1. The oropharynx was pink, moist, and free of any lesions or ulcerations. And then next, I'm going to assess your neck here. Let's see here. So I would say neck is symmetric, the midline. There's no swelling, masses, or discoloration noted. No JVD noted. And then I'm just going to palpate your trachea here with one finger at the bottom here, and then we're going to trace it up the top here. Any pain or discomfort with that?
Nope.
So trachea is midline with no deviation. All right, and then let's see. I wonder if could you have you sit at the end right here?
Yeah.
Thank you. Here. Yeah, just right about there. That should be perfect, actually. Let's see here. So I'm just going to be feeling for your thyroid here, so kind of relax the best you can. And then can you swallow for me? no masses or nodules noted. And then, no nodules are palpable. And then if you could turn your head slightly to the right and at like a downward angle. Let's see. No masses or nodules are palpable. And then I'll maybe do the same thing here. Turn your head to the left and slightly downward for me. This displaces the thyroid to the left side. We did it on the right side prior. And then no masses or nodules are palpable on this side either. Let's see here. And then I'm just going to kind of feel under your chin here and your throat area for, let's see here. So we're assessing for the lymph nodes here. Back of your neck here. And I'm gonna feel your collarbone here. The supraclavicular tap. The infraclavicular would be at the bottom here. And then all these lymph nodes that I felt here are, I'd say they're less than 1 centimeter. They're soft. They're mobile. Which is what we'd like to see. An abnormal lymph node would be enlarged, they may be hard, they'd be fixed, and tender to touch here. So, and then I'll feel it in front of your ears here. Go back. So these are the preocular, the postocular are the back, the occipital, the tonsillar, submandibular, submental, a little bit farther there. Perfect, thank you. Any pain or tenderness when doing any of that at all?
No.
Perfect. All right, and next we're gonna be looking at your posterior chest here. Let's see, so the posterior thorax is symmetric in size and shape. No lesions, scars, or masses are visible. Skin's pink, smooth, dry. Skin color is appropriate for his ethnic backgrounds. And then the spinous process is straight, and the scapula are symmetric. No unusual curvature noted. Here, no structural abnormalities are visible, and I'd say the AP diameter ratio is about 1 to 2 roughly, which is what we're looking for. And then the patient is sitting relaxed and comfortable. So to begin with, we're just gonna palpate bilaterally, and just let me know if you have any pain or tenderness noted. I'm just gonna kind of palpate all around your back here, lower back. Any pain or tenderness?
No.
Perfect. So no masses, thrills or heaves are noted. And then can you take one big deep breath here for me?
Yep.
Perfect. One more if you could. Perfect. So I'd say expansion is symmetrical, and then next we're gonna look for a tactile fremitus. So if I could have, so what I'm gonna do is you're gonna say 99, and as you say that, I'm just gonna kind of move over your back here. So just keep kind of saying 99 for me if you can.
99, 99, 99, 99, 99, 99, 99.
Perfect, thank you. So vibrations were clear, strong, and symmetric. No dullness or fluid noted when he was saying the 99 throughout that. And then next we're gonna percuss here. And then, so describing the sounds, resonance is hollow, clear, and it's low pitch lung sounds. Dullness is consolidation. Hyperresonance is increased air-filled area, such as with, like you typically see that with either COPD or emphysema. And then if you hear a flat sound, it means you're over bone. So I'm gonna have you lean forward a little bit here. And then I'm just gonna percuss here, and to do percussion, I'm gonna tap my third digit, and we're gonna go by 8 sites and all 3 apices. Let's see here. So just let me know if there's any pain or tenderness here. I'm just gonna move the camera here a little bit so we can see the whole view here. Go a little lower. Perfect. So all lung sounds are resonant, and then to assess for CVA tenderness, get a little lower here. Camera keeps going. There we go. So this will be in the lower back here, right around the 12th rib, and then just let me know if you have any pain or tenderness here. Perfect. No pain or tenderness noted. Let's see here, and then we're gonna auscultate all these areas. And as far as describing these sounds, bronchovesicular sounds, they're heard over the mid-scapular area. And then the vesicular lung sounds are heard over the lung periphery. And ambititious sounds, that would include wheezing, rhonchi, rales. And then, so with each patient, we'd clean the stethoscope. And you're sitting upright here. So if you could just lean forward slightly for me. And then take a deep breath in every time you hear or you feel the stethoscope move, if you could. And then just stop if you feel dizzy and let me know. But here, take a deep breath here for me. Perfect. Good. Good. And then we got 2 left here. Good. And then the last one here. Perfect. And then next we're gonna test for egophony. So I'm gonna have you repeat E. You're gonna say E every time you feel the stethoscope move, just like prior, but you'll be saying those here. There you go. E. Perfect. E. 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 Perfect, thank you. Let's see here. So I only heard a muffled E sound, no change to A. So there's no evidence of fluid or consolidation in the lungs. Lungs are clear to auscultation bilaterally. Let's see here. And then next we're gonna look at the front of your chest here. So if I could actually have you kind of spin here towards the camera here for me. Perfect, thank you here. And then, so we're looking at the anterior chest here. I would say it's symmetric in size and shape. AP diameter is less than the transverse diameter. Shoulders symmetric both sides here. No lesions, scars, or masses visible. No structural abnormalities noted. And then skin is smooth, dry. It's appropriate for his ethnic backgrounds. Respiratory rate, it's quiet, rhythmic. It's unlabored. There's no use of any accessory muscles. Nice and relaxed. And then I'm just gonna kind of palpate around your chest here. Just let me know if you have any pain or tenderness here. Any pain or tenderness there?
No.
Perfect. So no pain or tenderness noted. No unusual masses noted. And then let's see here. So and the next time I'm gonna take a kind of a listen to your chest here. Let's see here. So I'm just have you breathe normally, just like you were doing prior here. And then as far as describing the sounds, bronchial breath sounds are located at the upper part of the respiratory tree, over and then over the trachea area, and that's on the anterior side only. And then vesicular breath sounds are heard over the peripheral lung tissues. And rhonchi or wheezes or adventitious sounds that would indicate like COPD or something like that here. Let's see here. So next I'm gonna take a listen here. So just do the same thing. Take a deep breath every time I move around here. Good. Perfect. Good. Good. Go into the rib there. Perfect. One more over here. Good. Any pain or tenderness when you're taking those deep breaths?
Nope.
Awesome. All right. So next we're gonna kind of listen to your heart here, and we listen to those over. There's 5 points here. We have the aortic, which is located about right here. That's the second right intercostal space along the sternal border, and then this is called the base of the heart. That's where S2 would be best heard. And then right across from that, on the other side here, is the pulmonic. This is the second left intercostal space along the sternal border, and that's where a split S2 is heard best. And then this is the only sound that could vary with inspiration. Let's see, and then right below that point, about here, is called Erb's point. This is the third left intercostal space along the left sternal border. And then a little bit lower is the tricuspid. That's the fourth left intercostal space along the left sternal border, and that's where a split S1 is heard best. And then a little more over here, this is the mitral, and that's along the fifth intercostal left midclavicular line, and this is called the apex. This is where S1 is heard best. And then so the fifth spot is the mitral. This is located at the fifth intercostal space, left midclavicular line, and this is called the apex. S1 is heard best here. And then if we had the patient lie in left lateral decubitus position, this is where you'd hear S3, S4, and mitral valve prolapse would best be heard at this point as well. And then the last region we have here is the epigastric area. It's just below the xiphoid process, and it's just left of midline, so more on this left side here. And then this is where you may feel pulsations if there is heart hypertrophy. And then, as far as mitral regurgitation, murmur, and aortic stenosis, this is best heard during systole. And then next we'll be going over the squat test and the Valsalva maneuver. So as far as the squat test, we listen to the mitral area with the patient standing. The patient would squat, and if you hear the click resolve, that may be due to mitral valve prolapse. If the click were to increase, that may be the opening snap or aortic stenosis. And as far as the Valsalva maneuver, the patient would lay supine, and we listen to the mitral area again. And as the patient is laying back, you would place your hand on the abdomen, have the patient bear down like you'd be having a bowel movement. And if that click increases when the patient is bearing down, it may be a mitral valve prolapse. If the click resolves or decreases, then it could be aortic stenosis. And then next, so I'm just going to inspect the precordium. So if you could just, we're going to have you lay down again, actually, here.
Mm-hmm.
Let's see here. So yeah, if I have you stand up a little, move this, kind of slide it back over. Create our bed there kind of again. Perfect. Yeah, if you just want to focus your hand. Okay, so we're gonna palpate over all the precordial areas. Just let me move the camera. Let's see here. There we go. Should be good view here. Perfect. And then so we're just gonna go over here with pads of my fingers. We're gonna move over all the precordial areas. And I'm just feeling for any heaves or lifts. None noted so far. And then for the thrills, we'll use the ball of my hands. And then we're gonna go over each of the precordial areas again, feeling for any vibrations. Perfect. No thrills or pulsations were noted during that. And then next we're going to palpate for the apical impulse, which is the point of maximal impulse. So we'll have you lay supine here, and this is where we'll palpate the fifth intercostal space, mid clavicular line. So right about here. Perfect. And then the apical impulse was less than 2.5 centimeters wide. It was brisk, and it was less than 2/3 of systole. If the apical impulse was laterally displaced, it may be due to an enlarged heart. That wasn't felt here. And then if the apical pulse is hyperkinetic, it may be due to a number of things like young age, recently exercising, hyperthyroidism, or like aortic stenosis. And then next, we're going to take a listen to your heart instead of the lungs here. Let me grab my stethoscope here. So I'll just have you breathe normally throughout this process here. And we're going to listen with the diaphragm to all 5 of those precordial areas. So we'll start here. So I heard the heart sounds as a regular rhythm and rate. S1 and S2 were heard. No S3, no S4, no murmurs or rubs or any gallops. Let's see here, and then so typically we'd have you lay in the left lateral decubitus position, and then we listen to all 5 of the precordial areas laying in the left lateral decubitus position, but we won't be doing that here today. And then next we're going to be listening to arteries for any possible bruits, and we'll have you lay like this again. You're about 30 degrees already here, and first we'll begin with the carotid arteries on each side of your neck here, and we're going to be using the bell to listen to these arteries here. So I'm going to have you hold your breath here actually for me. Take a deep breath, hold in here, get on the side of your neck here. Alright, you can breathe again. And I'm going to do the same thing on the opposite side here. So take another deep breath for me, and hold. Perfect. You can breathe normally here. And then next I'll be listening to the abdominal aorta. And we'll be listening for any aortic bruit. Bless you. So, and then the abdominal aorta is right in the center here. It's between the xiphoid process and the umbilicus, and it's right in the midline there. Perfect. No bruit was heard, and we used the bell for that one as well. And then next, we're going to be looking for, we'll be listening to the renal arteries, and we'll be using the bell as well. And these are located just below the abdominal aorta, and they're lateral to midline on both sides here. So we'll be listening to those. So if I could have you just put your hands on your side there for me. We're just going to take a listen to each side here. And no bruits heard there. Perfect. And then next we're going to listen to your femoral arteries with the bell as well. These ones are a little lower on each side. They're I would say about halfway between the superior iliac spine and the pubic symphysis. And then they're within the groin range, both sides here. So I'm going to take a listen here. Perfect. We'll do the same thing on this side. Perfect. No bruits were heard, and that was with the bell here again. That's good there. And then next we're going to be assessing pulses. And pulses are graded on a scale of 0 to 3. A 0 means there's no pulse. 1 plus is weak. 2 plus is brisk, and that's what a typical person would have. And then 3 plus would be a bounding, kind of a racing pulse there. Radial pulses, just on top of the wrist here. We would listen for 60 seconds. And we would do that on both sides. So we can do that here. If I could have both your hands here. Listen to both of these here. Just relax the best here. And we'll do this for 60 seconds here. Radial pulses were 2 plus, which is to be expected, no worries there. And then the femoral pulses, they're about halfway between the superior iliac and the pubic symphysis bilaterally, and they're right below the inguinal ligament. So we won't be doing that during this assessment, but if I could have you actually sit on the side of the bed here. Over here. Perfect. Yeah, so we can see both your knees here. And here we're going to be looking at your posterior tibialis. Let's see here. Perfect. So, but the ankle, I wonder if we get the ankle view. So for the posterior tibialis, they're right on the side of the malleolus there. If I can get an angle there. Holding it off, right? Oh, this way.
Yeah, you should be able just to flip it, right?
All right, so next we'll be looking at the popliteal pulses here. So I'm gonna kind of grab your knees here. We're just gonna listen. We're just gonna feel for the pulses in the back there. So we'll do that on both sides here. Both sides. We got that on camera. There. Perfect. Equal and about 2 plus on each side there. So the popliteal pulses, and then as far as the posterior tibialis, so we'll have your knees bent like this, and for this pulse, it's just below the ankle on the malleolus there, just on the side there. So I'll be feeling both your ankles here, for both of those pulses. Perfect. We got 2+ on those as well. And then the last pulse we're gonna be checking is the dorsalis pedis. So we'll keep your knees bent here, and these are just on the top of your feet here. Just lateral of the extensor tendon and the great toe here. So we got your left foot here, 2+, and right foot, 2+. So bilateral 2+ for the dorsalis pedis pulses. And then as far as checking for edema here, let's see, no pitting edema on your feet or ankles here. Let's see here. So yeah, so when we push down, there's no depression for 1 to 2 seconds. Everything bounces back quickly. That's graded on a scale of 4+. So pitting edema is swelling when you push your thumb that's depressed after 1 to 2 seconds. Dependent edema forms a pitting edema, but occurs in the lower extremities from if you're standing for a long period or if you're sitting for a long period. And then anascara edema, that's just generalized edema, and that's usually due to like liver or kidney dysfunction. Let's see, and then as far as skin temperature, you're warm. Skin temperature, we have warm for upper and lower extremities. And then if you're sitting up for me, I'm gonna check your collarbone. We're just gonna check for a skin turgor, just to make sure you're well hydrated and everything. Perfect. Skin bounced back quickly there. So there's no tenting on the collarbone area, and then we're gonna test for capillary refill. So if you just hold your hands out here, squeeze your fingertips there. Perfect. We'll do the same thing with your toes there. Perfect. So capillary refill was less than 2 seconds for both upper and lower extremities. All nails were smooth, they weren't rounded or anything like that. Let's see, and then next we're just gonna assess your abdomen here. So abdomen is symmetric. There's no lesions, scars, no masses are noted, no pulsations are visible. If pulsations were visible, it could be possible due to like a AAA, and then we would not palpate that area. So next we're gonna auscultate kind of your stomach area, just kind of like we did with your chest, but this time in the abdomen area here. And this is gonna be over about 1 to 5 minutes here. So if you could just, we can have you sitting like that actually. So you can just breathe normally during this here. And we're gonna start in the lower right quadrant here. Perfect. Good. Perfect. So we got that. So that's done over 1 to 5 minutes, and then I'm actually gonna listen over your spleen and your liver for any friction rub here, and then friction rub, that'd be like a grating sound, and that may vary with respirations. It indicates a presence of inflammation on the peritoneal surface of organs, possibly like a liver tumor or a chlamydia or gonorrheal infection. Let's see. And then with friction rub, that'd be heard over the liver, and that we could consider like a hepatic carcinoma. But with this patient, there was no friction rub heard on this patient. I would be listening for like a venous hum, which is a soft systolic and diastolic hum that may be heard over the liver, epigastric, and umbilical region, kind of right in the center there. And that indicates an increased collateral circulation with hepatic cirrhosis. Let's see, and then next we're gonna kind of percuss this area here. So we're gonna do the same thing kind of like we did with your back here. First, and do it over your abdomen here. All right, so now we got the patient lying down again here, and then we're just gonna percuss kind of your abdomen here. We're gonna start in the lower right quadrant here, and we do that by tapping my third finger here. So sound was tympanic throughout the abdomen there, and then we're gonna check for a hepatomegaly. It's a tongue twister there. We're checking the liver here though. I'm gonna start percussing with my left finger here at like the third intercostal space, mid-clavicular line here. What I'm doing here is percussing down until dullness is heard. At that point, we're gonna mark, and then we're gonna percuss from below the umbilicus, and then we're gonna move mid-clavicular line, move up until tympany to dullness is heard. And the measurement should be between 6 and 12 centimeters, typically here. We got I would say about like 8 or 9 centimeters here. So that's completely normal and to be expected. And then so we're gonna do light palpitation across your abdomen here. Just let me know if you have any pain or tenderness. And I'm gonna also be looking for any masses in the abdominal area here. So we'll start with light palpitation with just one hand here. Next, we're gonna go a little deeper here. So we'll put one hand on top of the other. We'll push a little deeper here. Any pain or tenderness or anything?
No.
And then we just want to find the bottom of the ribs here, and we're kind of hook, and this is checking for any hepatomegaly or splenomegaly. We'll do that on both sides here. Kind of hook under the rib here. Is there any pain or tenderness?
No.
Oops, sorry. We'll do the same thing on the left side here. We'll kind of hook under the bottom ribs there. Perfect. So we're all good here, and then we do have a couple kind of special tests that we do, and these tests for appendicitis. The first one is the psoas sign. So I'm gonna place a hand on your thigh here, and then just raise your leg up against my hand here. You just raise this leg up. Any pain?
No.
Perfect. So he has no pain. If the patient did have pain, that's a sign of appendicitis. And we have another test here, which is the obturator sign. So we'd have knees bent. So if you could bend this knee here for me, this one. Perfect. We'll do that. And then if we would do inward rotation. Any pain with that one?
No.
Perfect. So he has no pain. If he did have pain, that would be another sign of appendicitis. And then the next we'll assess for rebound tenderness. So we'll go in the lower left quadrant here. So we're gonna apply pressure here, and then we'll release. Any tenderness feeling now?
No.
Perfect. So he has no rebound tenderness. If he did, that's another sign of issues there. And then the last one is the Rosping sign. So on this one, we're gonna press in the lower left quadrant here, and then we're gonna quickly release. And then if you were to have pain on the right side, that's a sign of appendicitis. So we'll do that here. Any pain on the right side, right?
No.
So he has no pain, so that's a negative negative Rosping sign. And then so to test for the cholecystitis, we have a Murphy sign. So we're gonna press our fingers under the right rib cage, and then I'm gonna have you breathe in here for me. Perfect. Any pain? Perfect. So he was negative for that. If he did have pain on inspiration, that would be a positive Murphy sign and a sign of cholecystitis. And then next, we're actually going to have you stand up here, and we're just going to assess the neurological system. This is our last little bit here. So we're going to check balance and coordination here. So we'll have you stand. Why don't we move this out of the way here, actually? Give us a little space. We don't have a lot here. All right, cool. If you stand. So if you just walk towards the camera. And then we'll have you walk back. Just spin around, you just walk normally, yeah. Sorry. So patient's gait is smooth, steady. He has natural arm swing, no steppage gait. And then next we're gonna perform it's called a Romberg test. So I'm gonna have you close your eyes, and you're gonna keep standing for 1 minute. All right, perfect. And then for this last part here, we can actually have you sit down again. So we'll put that here. And then he had a negative Romberg sign, which is to be expected. So next we're gonna do it's called a point-to-point test. So we're gonna have you touch your thumb to all fingers as fast as you can. Can you do that for me? Perfect, and you can do it on both sides for me. Awesome. So movements are smooth, they're accurate, no tremors noted. And then last one, we're gonna do heel to shin. So what you're gonna do is your heel, and you're gonna drag it up so like your right heel or your left heel, and just drag it up and down. Perfect. If you do that with the other leg as well. Perfect. So good movements, smooth and accurate. And then the next we're gonna do, it's called pronator drift. So we're gonna have you hold your arms out with your hands up, and you're gonna hold that for 10 seconds. 1, 2, 3, 4. Perfect. You can open your eyes. You can put your arms down there here, and then we're gonna have you do that again, but this time with your eyes closed.
Okay.
So whenever you're ready, if you want to do that. Perfect. We're gonna hold that for 10 seconds. Perfect. No pronator drift noted. And then next we're gonna test for sensory function. So again, we're gonna use those sharp and dull objects here. And just close your eyes. And then just tell me if you feel sharp or dull.
Keep going.
Yeah.
Dull.
Perfect. We'll do the same thing over here.
Dull.
Dull. Upper arms.
Dull. Sharp.
Perfect. And then we'll do your feet.
Go good. Dull.
Dull. Perfect.
Sharp.
Perfect. And then we'll do your feet.
Sharp. Dull.
Perfect. So sensation is intact for both sharp and dull. We tested his arms, forearms, upper arms, feet, ankles, and legs. And then next we're going to be looking at discriminative sensation. So we'll have you close your eyes again, and we'll have you open your hands. And just tell me what I put in your hand.
Q-tip.
Perfect. All right, so sterognosis is intact, and then we're gonna have you keep your eyes closed. We're gonna have you open your hands, and then just tell me what number I draw on your hand.
Can you go again?
Yeah.
4.
4, perfect. And over here.
8.
Perfect. So you got both of those right there. So graphisthasia is intact. And then discriminative sensation is intact bilaterally via sterognosis and graphisthasia. Let's see here. So, and then we only got a couple tests left here. So we'll be looking at the meningeal signs here. So if I could have you lay flat on the table.
Mm-hmm.
You do, and I'm just going to be kind of moving your head here.
Mm-hmm.
We're going to move his head to his chin. Perfect. So we got a nice smooth movement. No flexion of the knees or hips occurred. So that's a negative Berdzinski's test. And then we're going to keep the patient laying flat here. Just relax your legs, and then we're gonna pull straight legs, and then I'm just gonna pull one of these legs up here. Perfect. Any pain in your back?
No.
Same thing here. Any pain in your back?
No.
And then he had no pain in his back. I didn't feel any resistance when he tried to straighten his legs, so that equals a negative Koenig's test. And that actually concludes our exam, so thank you for all the help.